Disclosures. I'll leave these up for just a second or two. And if anybody needs to see these later, I'm happy to share them. Okay, so really, I wanted to focus on not a lot of old data, but to really focus on what's been going on in this dynamic space of HER2 positive breast cancer over the last 1 to 2 to 3 years or thereabouts. And here's some names of some studies that we'll review. I do want to reflect on what's been going on with our pathologic assessments of tissues because they drive our ability to get access to these new medicines. We'll just definitely discuss sequencing as I see it in the United States through the NCCN and other supported guidelines, reflecting, of course, on how that might be different in a place like Ontario. And then finally, just closing up a little bit on breast cancer brain metastasis and the unique needs around that. In the United States, we have this TV show, Modern Family. So this is my riff on that, the modern EGFR family. This is a group of conserved receptors in mammalian evolution. There's 4 of them, and they go interchangeably by epidermal growth factor receptor, or EGFR, or in humans, human epidermal growth factor receptor, or HER. And there's, as I said, 4 family members, HER1 or EGFR1, HER2, 3, and 4. And these are at some normal level on most tissues, on most epithelial tissues, and mediate some aspects of cell maintenance and growth. However, when you have HER2 amplification or overexpression, instead of having the normal 100 to 1,000 copies of this protein on a cell surface, you will literally have millions. And when this happens, these molecules stochastically will start colliding with each other. And once they do that, they form these little signaling complexes on the inside of the cancer cell, which then can lead to RAS activation and go down that pathway, or more commonly lead to PI3 kinase activation and then mTOR, AKT, et cetera. And ultimately, a very strong proliferative signal is sent to the inside of the cell. When you look at this in the tissues, they can range from 0 to 3+ in terms of their staining. 0 literally means there's no staining on the cells. And on the other end of the spectrum, 3+ is this very dense circumferential staining around each of the cancer cells. 1+ and 2+ is intermediate of that. And when it's 1+ and 2+, it's our understanding that these are cancers where the protein is not sufficient to be a driver. It's not actually driving the cancer. I make a big stink about this right now because even though it's not a driver, sometimes you can have enough of the protein on the surface to use as an attachment mechanism for things like antibody drug conjugates, some of the most recent ones being so potent that they can be effective. So I just want to distinguish this a little bit further. So what do I mean by when HER2 is a driver? Well, when HER2 is overexpressed, as in that 3+ staining, or HER2 is amplified, which is ultimately associated also with that type of staining pattern, it can be targeted as a mechanism to hurt cancer cells. This is a very old study I'm showing you here, phase 2 study of lapatinib, a reversible small molecule tyrosine kinase inhibitor. And you can see it's not a very potent agent, but you do see activity against HER2-driven cancer cells in this small trial. However, when you are HER2 low or 0 or not over amplified, you see no responses in that setting. In the early breast cancer setting, we've also looked at seeing if we can use a drug called trastuzumab, a monoclonal antibody that elicits a very potent immune response when HER2 is not driven as indicated by FISH or doesn't have 3+ staining. So this is that sort of HER2 low group. And what you see is essentially in this randomized controlled trial where patients received either chemotherapy or chemotherapy plus trastuzumab for this patient group, there was no difference between the 2 arms. And as a result, it's our understanding that when HER2 is not a driver, HER2 mechanistically is not valuable in targeting for improving outcomes in this patient group. So what does HER2 mean in metastatic breast cancer in 2023? So when we say HER2 positive, we're typically in the metastatic setting, we're talking about FISH testing, looking for a ratio of generally greater than 2 to 2 compared to the centromere signal. And you can see a variety of different categories here in terms of how we get at this HER2 is amplified question. And I won't go through all of those, but it's a pretty detailed assessment. And certainly if you have immunohistochemistry and it's 3+, even in a metastatic site, it could be considered HER2 positive. So why am I making this big stink about HER2 all of a sudden? Well, what I've noticed is people post this Destiny Breast 04 trial in which HER2 low expression was targetable with a very potent antibody drug conjugate, people have started just saying, oh, I'm just going to get IHC for everything. And the problem with that in the metastatic setting is if you miss an IHC because of staining artifacts and the non-reliability in non-breast tissue, especially places like bone, of immunohistochemistry, and you don't do FISH and you don't identify somebody as being amplified, you've all of a sudden restricted access to a number of medicines that are extremely effective for HER2-driven disease. So in the metastatic setting, get FISH, and if it's negative, then make sure you get immunohistochemistry, because if you find somebody that is 1+ or 2+, then they have access to the antibody drug conjugate that would work in that setting. So this is a little bit different than what we do in the early breast cancer setting, where if anything, it's flipped around. We get IHC for those indeterminate cases, then we get FISH, and we're looking to escalate in that direction. Whereas here with the metastatic setting, it's quite the other way around. This is just some work showing kind of how hard this can be. So this is work we published looking at bone, where oftentimes it's very hard to stain for HER2. And so we were looking at different mechanisms by which we could identify HER2 expression. We had target protein, we used mass spectrometry, and we're basically able to show using mass spec that we could identify low levels of HER2 even in these tissues that were conventionally thought to be HER2 negative, and in some cases, really identify strong HER2 staining. So all this is to say, this is an evolving field. We're really trying to find how low we can go with HER2 at this point, but we certainly don't want to forget that when HER2 is a driver, we really need to find out who those patients are. So today I'm not going to talk about HER2 low disease. That's a topic of its own at this point. I'm really just going to focus on these HER2-driven cancers. And here, this is just a snapshot of what that toolbox looks like. I mentioned trastuzumab. This is the therapeutic monoclonal antibody that helps engage immune cells, particularly NK cells, and elicits an immune response. Pertuzumab is another therapeutic monoclonal antibody that essentially wedges itself between the HER2 dimers or homodimers, heterodimers, and rips them apart such that the signaling complex is not formed on the inside. You have margetuximab, which is available in the United States, where the Fc receptor portion of trastuzumab has been modified to better engage NK cells and lead to a better immune clearance. We also have the antibody drug conjugates, where we basically take in trastuzumab or similar molecules, attach very potent chemotherapy, which then, when internalized, gets liberated in the lysosomes, and as a result, this proteolytic cleavage will be free to damage the cancer cells based on the mechanism of action of whatever that chemotherapy payload might be. There's a couple drugs approved now in this category and more anticipated. On the other hand, once we're in the inside of the cancer cell, we have these small molecule inhibitors, 3 of which are specifically approved by the FDA for targeting HER2 positive disease. And then you see across the country, across the world, many people have other small molecules that are also capable either completely or partially blocking HER2. And once you shut those down, all this downstream signaling goes away. As you can see here, there is some downstream signaling, and there are molecules that target this. So you can envision, at least in those cancers such as co-driven cancers with estrogen receptor expression, we may be able to co-target some of these other pathways. That's certainly been done with the CDK4/6 inhibitors and certainly with the addition of endocrine therapy, but there's some novel combinations that might merge as well. So this is a very high-level overview of what's in our hands now, what's about to come. And then, of course, there's more things like peptide vaccines and CAR-T and other fancier therapies being developed against this disease. When we look at kind of the NCCN, these guidelines that we use in the United States, but generally are used throughout the world, especially for countries that don't have their own agencies to do this type of work, we have basically maintained at the first line metastatic setting this combination that I call the Cleopatra regimen, involving a taxane and the 2 therapeutic antibodies. We also now in the second line, based on some data you'll see shortly, have elevated this antibody drug conjugate called trastuzumab deruxtecan, or TDXD, into that second line. And in the third line, we have now a 3-drug combination involving the drug tucatinib, again, data which we'll present. TDM1 has kind of fallen down the ladder a little bit. And I will just point out, in certain circumstances, tucatinib might be elevated into the second line, depending on what's going on. Beyond that, we have a variety of choices available to us in terms of combinations with trastuzumab, potentially with other small molecule inhibitors. So a lot of activity going on there. but I do generally encourage people across the spectrum to consider research trials when available. So on our side of the border, this is how things really do go. We do use a lot of these agents in the adjuvant setting as well, in the early breast cancer setting. And if that's happened and a patient has still recurred, although that is less likely these days, we then push some of the agents we had in the second, third, and fourth lines, for example, up a line of therapy. So you can see, for example, trastuzumab deruxtecan being used essentially in the first line in a patient like that, and tucatinib maybe even in the second line. But for patients who present here with de novo metastatic disease, it is still by convention a combination of these two drugs followed by this, potentially this, depending on context and so forth. So lots of options here depending on what a patient has been on before. I realize on your side of the border, things are a little bit different. This is a provisional funding algorithm where for patients with early stage disease, the time course of relapse, whether it's less than 6 months or greater than 6 months, will determine the choice between re-challenging with the dual antibodies and a taxane versus moving on to the antibody drug conjugates. But then for patients with de novo metastatic disease, typically we'll start with the Cleopatra-like regimen, consider the second line with these antibody drug conjugates, and then the third line with tucatinib. But in certain contexts, particularly if there's brain metastases and other things, you might want to look at that third line a little bit differently. I realize that the workflow here is a little bit more rigid than what you might see in the United States in terms of access. For patients who want to see this earlier, it might compromise them from getting this at a later line. So with that caveat, I do understand some of the unique challenges on quote, your side of the border. So I'll start with Cleopatra because it's the foundation from which a lot of this work is built upon. This is a trial that was published now more than a decade ago for PFS, and then we got OS, and that OS data has continued to mature. This is last looked at in 2019, 8-year data now, and you're looking at overall survival of 37% versus 23% for the arm where no pertuzumab was used. So the 3-drug combination of the dual antibodies plus the taxane became the standard. And I just reflecting on this, I started my career in breast cancer in the mid-2000s, almost 20 years ago. And this number now today with this trial, which is already old, was 57 months for median OS. And when I started this, it was a mere 18 months. So this is really a remarkable improvement over time. And if anything, we all anticipate this number to be even better. However, it is still true that if you have metastatic HER2 positive breast cancer, you are still more likely to die of metastatic HER2 positive breast cancer than anything else, which means that the job is not done. We need to continue to work on developing new agents and bringing them to market. I like to talk about this trial. It's a small trial, but it does inform my patient care. It's been out a few years now by my colleague Mo Ramawi at Baylor College of Medicine. And this is a trial looking in the first line at how best to utilize pertuzumab in patients who have hormone receptor positive and HER2 positive disease. In the trial, it was really a study to see the value of pertuzumab, but they did this innovative thing where for patients who had endocrine positive disease, that they also used aromatase inhibitors, or in some cases may have pumped and primed the system with chemotherapy first and then followed with an aromatase inhibitor. When they looked at the entire study population, any receipt of pertuzumab was better than non-receipt of pertuzumab, a hazard ratio suggesting a 35% improvement, only a 3-month improvement in this small trial, but still supportive of what we watched in Cleopatra. However, when they looked at all the patients who had had chemotherapy as part of their recipe in this hormone receptor positive subgroup, you see no benefit from the addition of chemotherapy to pertuzumab therapy being added to this backbone. In other words, chemo plus trastuzumab in this trial was as good as chemo plus pertuzumab trastuzumab in this trial of ER-positive patients. However, when you looked at patients who only got endocrine therapy and no chemotherapy, the combination of targeting with dual antibodies as well as AAI therapy really lengthened the PFS for this patient group compared to trastuzumab and AI alone therapy. These numbers are actually in terms of gain and the hazard ratio, et cetera, are very, very similar to what was observed in Cleopatra. So why spend all this time on this topic? Well, it is to say that if you have patients who are frail or unfit or unwilling to give a shot with chemotherapy, it's perfectly reasonable to consider AI-based targeting of the estrogen receptor as in combination with the dual antibodies, because that can be very effective in those patients, and you may be able to earn their trust with treatment and then move on going forward. So the second line was established many years ago as well, with improvement over the then standard lapatinib plus capecitabine. This is TDM1, which is trastuzumab emtansine, a first-generation monoclonal antibody drug conjugate. Here you see a linker and this emtansine chemotherapy, stoichiometrically about 3.8 molecules per trastuzumab molecule. When we looked at this in comparison to then lapatinib and capecitabine, you see about a 3.2-month absolute improvement, a 35% improvement in the hazard ratio, and a significant p-value. And in addition, there was an overall survival benefit hazard ratio suggesting a 32% improvement for OS. So this had been established as the standard in that line of therapy following anything with trastuzumab and docetaxel type of chemotherapy in that first line setting. But then came the new therapeutic antibody drug conjugates. And the first of these in this disease space is TDXD, or trastuzumab deruxtecan. This is the phase 2 DESTINY-Breast01 trial, in which patients who had relapsed or were refractory to TDM1 were invited to participate in this trial, where initially there was sort of a dose-finding exercise. And then once they found the target dose, they actually enrolled at at that level, 184 patients. Because this was a phase 2 trial, they were powering for overall responses. However, because it was a large enough study, they were still able to look at things like PFS and OS. So this is our first look at this, but focusing on the response rates. The confirmed overall response rate was 62%. Many patients with CRs, many patients with PRs, or partial responses. And interestingly enough, a lot of patients with what we call stable disease. So stable disease, just to remind everybody, is cancer that had not progressed by more than 20% or had improved by less than 30%. So it's this group of patients from here to here. And when you add that stable disease plus the PRs plus the CRs, you get something called a clinical benefit rate. And the CBR in this trial was 98%. So only 2% of patients had disease progression as their best response. Most patients had some sort of value attributable to this drug. When they looked at the PFS, it was nearly 19 months in a group of patients who had seen as many as 11 lines of prior therapy, with a median of 5 or so lines of therapy given. So heavily pretreated patients still being able to eke out dramatic benefit in terms of PFS. So the FDA initially granted a conditional approval based on this data, somewhat unexpectedly, but based on the quality of the data, they said, we can't hold this up, but please do finish your phase 3 trial. And that brings us to DESTINY-Breast02, which has now been presented a couple times, and this is the original presentation from Ian Kropp. Here, very similarly to the patient population that was treated in DB01, patients were randomized 2-to-1 for the target dose with 406 patients and 200 patients receiving treatment of physician's choice, which could be CAPE plus trastuzumab or CAPE plus lapatinib. The primary endpoint was PFS now, a survival endpoint, but also overall survival. And what they observed was a very dramatic rightward shift for PFS with a p-value with 23 zeros in it, hazard ratio of 0.35. And here, when you look at the median PFS, it's about 18 months, and very similar to what was observed in DESTINY-Breast01. So reassurance that this was actually the real deal and not a fluke. When we looked at the subgroup analysis for this trial, you see hazard ratios that are very consistent, supporting nearly a 45 to 70% improvement in PFS across all these pre-specified subgroups. And then we also had overall survival being reported as an early endpoint. And you can see here at these landmarks of 12 months and 24 months, a stable difference between the two arms appeared. Medians were 39 months versus 26 months. P-value trending in the right direction, suggesting a 35% benefit. This data will continue to be updated over time. I will talk about the toxicity in a minute, but just to know in this trial that the toxicity was consistent with the label at the time. So this brings us to Destiny Breast 03. So this is a trial now saying if this antibody drug conjugate is as good as we think it is, it should be better than the standard that we're using in that second line of therapy, i.e. trastuzumab emtansine or TDM1. This is a trial that was a 1-to-1 randomization, initially intended for 500 patients. They ultimately enrolled about 520 patients. And you can see there was a dramatic improvement just based on this PFS curve with a rightward shift, the hazard ratio suggesting a nearly 72% improvement in PFS, very statistically significant. When they looked here at the subgroups as well, many of them locked in tightly towards the left, suggesting a benefit for trastuzumab deruxtecan for all these pre-specified subgroups. And then finally, when they looked at overall survival, this first look when it was first published in the New England Journal, even though the medians had not been reached for either arm, you do see an immediate separation of the arms, and it does not look like they're going to find each other again. So this was updated in San Antonio last year, so a little over 10 months ago. And what we see here is a p-value that continues to be trending in the right direction, and a 36% improvement in OS in this trial. The median still not reached for either arm, so patients overall performing well, but very likely that these curves will not find each other over time, and an overall survival benefit will be locked in this trial. I didn't want to talk about toxicity until we got to a phase 3 trial, just so we could see it compare and contrast. So we'll do that in the context of Destiny Breast 03. So looking at the toxicity tables, what strikes me right away is that TDM1 is, first of all, a well-tolerated agent, and TDXD is a agent with more toxicities, more side effects. The big one to note, of course, are in the hematologic compartment. You see worse neutropenia, 42% all grades, 20% for grade 3, compared to only 3% over here. When you look at thrombocytopenia, toxicity classically associated with TDM1, you see that's almost 25% and only 7% over here. In terms of sort of day-to-day tolerability issues, you can see, consistent with a payload of a topo-1 isomerase inhibitor, a lot of GI stuff going on. Most of it low grade, but some of it serious and high grade, and very little of this in the TDM1 arm. I will just also comment that the most recent NCCN supportive care guidelines have now classified TDXD as a chemotherapy that's highly emetogenic. And why that's important is in the US, we're allowed to give preparatory drugs for chemotherapy consistent with the aggressiveness that we need to match for the chemotherapy itself. And now with this being classified as highly emetogenic, we can use prophylactically some of the most potent agents we have to prevent this nausea from happening at all. So it enables us, but it's still an indicator of how much nausea is potentially caused by this agent. I'll talk a little bit about alopecia. You can see here it's very rare to see any alopecia with TDM1, but it's very common to see it with TDXD. About 40% of patients experiencing complete hair loss or something less than that. There's one funny finding here that some patient somewhere got admitted for care for hair loss. There's no real thing as a grade 3 hair loss toxicity, so I always find it curious when we see this in a trial. I'm going to defer talking about pneumonitis just for a second, because I want to spend a little bit more time on that. So one thing that people always worry or question is when we assess for toxicities in clinical trials, we just record them whenever they happen, regardless of what time course they happen over. And the problem with that is, especially in a trial like this, where TDXD is so effective that patients are retained on it for longer, per unit of time, it may be that there's fewer toxicities associated with TDXD as opposed to TDM1. So this group of investigators, in this presentation by Erica Hamilton at ASCO 2 years ago, they created this thing called the exposure-adjusted incident ratio. And then they looked at the serious adverse events, any grades, all grades, and milder serious adverse events. And what you basically see is a lower ratio for TDXD than what you see for TDM1. And so led the investigators to conclude that when you look at this exposure-adjusted incident rates of toxicities, they're actually lower with TDXD than they are with TDM1, suggesting that this might be a more tolerable agent over the long haul, especially in light of its efficacy. And then lastly, DB03's pneumonitis ILD rates. Just keep in mind when this drug first came on the market and we were looking at those early phase studies, patients literally had died as a result of being on this drug and suffering pulmonary complications. We learned our lesson, and on these later trials, we're more cautious about pushing our luck with the therapy. We held based on any cues of shortness of breath, and we even held based on imaging findings suggesting pneumonitis could be going on. Some of those patients, of course, were re-challenged, but at the end of the day, we eliminated the grade 4 and the fatal events, grade 5 events with this drug. So that's quite reassuring that we could educate ourselves to become that good at this. Overall, when you looked at ILD and pneumonitis, it was the main cause leading to discontinuation of TDXD, and it occurred in 8% of patients. And not surprisingly, thrombocytopenia in about 1 in 30 patients on TDM1. Having now talked about what goes on and what we can do on the outside of the cancer cell, let's now go on the inside of the cancer cell. So what you're looking at here on the left are what we call kinograms. This is an evolutionary mapping of all the kinases and their interrelatedness based on structure and other features. And you can see with a molecule like neratinib, something we might call a dirty kinase inhibitor, it certainly hits the EGFR family, but you see that it hits other families as well on this tree. And why that matters is, A, it could be more effective as cancers recruit other types of kinases to help them grow, but it's also the leading cause of why you see toxicities with these kinases, that as you hit these other molecules, maybe there's some normal functions that are being disrupted. When you look at tucatinib, you see a different story emerge. It is very tightly associated with EGFR inhibition. And when we look at the actual binding constants, this IC50s, and you see for both of these drugs, all three of these drugs are in the nanomolar range. Let's start with lapatinib. It's a reversible inhibitor, weakly binds HER2, a little bit more potent at EGFR1. Neratinib tightly binds HER2 and even more tightly binds EGFR1. And tucatinib binds HER2 nicely and leaves essentially EGFR1 alone. So why does this matter? Well, as we know, these two drugs have a lot of EGFR toxicities. By that, I mean diarrhea and rash. And so this profile of how the kinases are inhibited is really directly related to the toxicities we see. And so that gives us some ability to understand how best to use these molecules. I'll start first with the HER2 CLIMB trial. This is a trial looking at a 3-drug combination of tucatinib, a HER2 kinase inhibitor, combined with oral chemotherapy and trastuzumab, versus that same combination minus tucatinib and instead adding a placebo. 2-to-1 randomization. When this trial was first designed by Cascadian Pharmaceuticals, a small biotech company, they said, oh, we can do a 480-patient trial, and we're really going to focus on PFS in these patients. When the trial was, when the molecule was acquired by then Seattle Genetics, now we call it Seagen, they increased the funding for the trial and basically empowered it to look at PFS in patients with brain mets. They felt that this was going to be an important use of this molecule. When they looked at the patients who had enrolled, just to note that this was potentially a very vulnerable population that could get sick quite quickly. 74% of the patients had visceral metastasis, and about half the patients had brain metastasis. But these were not the simple treated brain metastases you would see on other trials. Certainly 40% of those patients were like that, but 60% of them had really what we call active brain metastasis, 23% with untreated progressing brain metastasis, and 37%, most disconcertingly, with treated but progressing brain metastasis. These are the true bad actors. Historically, these patients have very poor outcomes and very poor survival, and a lot of drug companies were skittish about proactively enrolling these patients to studies because they knew it ultimately would wash out their signal for benefit. However, the strategy here, knowing that tucatinib crossed the blood-brain barrier, was essentially tightly binding HER2, was that maybe this is a drug that would be particularly effective for those patients. So the HER2 CLIMB study was, of course, published by Reshma Murthy, published in the New England Journal and so forth, and now it's been updated a few times. So again, just focusing on the most recent updates here in the Annals of Oncology, the PFS remains good and robust with lots of zeros in that p-value and a hazard ratio suggesting a 43% improvement. And even though that's only looking from this direction to this direction, when you start looking at the landmarks at 6 months, 12 months, 18 months, what you see is a very consistent separation between the two curves, suggesting a group of patients that are stably benefiting from this drug. When we look at overall survival, which has also been updated, a 27% improvement here, a p-value that's significant, and almost a greater than 5 month, 5.5 month improvement by absolute numbers. And here again, that's depicted at these landmarks of 12 months and 24 months, showing a stable difference between the two curves, unlikely to find each other at a later time point. We talked about disease control with the antibody drug conjugates. Now, what does disease control look like with a small molecule inhibitor? We talked about 98%, and here you see with tucatinib, it's 92%. So this is still a very good number, a number many of us would be jealous of in any trial we design. When you look, a handful of patients with CRs, lots of patients with partial responses, and a really large fraction of patients with stable disease. And when you add all of this up and you get that clinical benefit rate of 92%, and you just focus on the overall responses, it's 40%. One thing that's not shown here in sort of exploratory analysis, this group of patients with just stable disease were also associated with an improvement in OS as well. So there's value here for the stable disease. And then the last thing, we talk about these ADCs as being very, very active, delivering results quickly, et cetera. You can see here even by the time on study, a patient was evaluated for their first on-treatment scan, many of them had already started responding. So this is an active combination, certainly appropriate for patients with visceral disease, and also very, very likely to work in brain metastasis, data I'll show in a little bit. When we look at safety with the HER2 CLIMB recipe, given the sort of narrow binding of to HER2 kinase, we didn't anticipate a lot of toxicities associated with that agent, and these data tables bear that out. When you look at, for example, serious adverse events of diarrhea and hand-foot syndrome, it's only a few percentage points greater than the group that got placebo. And here again, you have to reflect on this group of patients was on therapy much longer than this group of patients. So the possibility of reporting toxicities related to capecitabine, which accrue over time, was greater. So at the end of the day, they did this analysis to see what was the percentage of people stopping tucatinib as a result of toxicities. In the early analysis, it was about 1 in 30 patients discontinued the drug for reasons of toxicities attributable to tucatinib. In the updated analysis, it was actually 1 in 50, so 2% of patients overall. That number is extremely low, especially when we reflect on some of these other antibody drug conjugates we've been talking about. So really overall, the picture of a tolerable agent and a tolerable combination. I'm going to move a little bit with neratinib. Some data here as well in the last few years got lost in the shuffle as the pandemic started taking place, but this is a positive trial that did lead to an FDA approval. NALA was a study where they looked at the old standard of capecitabine being added to lapatinib and instead now being added to neratinib. Patients, because of the mechanisms of how these drugs work, lapatinib is a reversible inhibitor, neratinib is a irreversible inhibitor. It would take a while for lapatinib resistance to emerge. And so for a long time, these curves were always anticipated to kind of travel together. And the company appropriately was worried that if that was the case, they would not be able to show a difference for the median of PFS with neratinib over lapatinib. So as they designed the trial and negotiated with the FDA, they said, instead, what we're going to do is we're going to look at restricted means analysis focusing on 24 months, essentially looking at what happened at 24 months. And when you integrate the area under this curve, you see it is actually better with the neratinib combination as opposed to the lapatinib combination, p-value of 24% improvement. An absolute improvement of only 2.2 months. So this is a positive trial, led to the FDA approval. There was a co-primary endpoint of overall survival, and you can see even though there's a 12% improvement, this was not a positive finding. So all the approval really is based on PFS. This small molecule inhibitor is capable of crossing the blood-brain barrier, inactivating HER2 and HER2-driven cells. And we would expect then if there was micrometastatic disease in the brain that had not yet manifested, we should be able to control that. So this actually asks that question in comparison to lapatinib, and you see over time, fewer patients on the neratinib arm develop brain metastasis. So this is some evidence that targeting the CNS disease in this manner could be helpful as sort of a prevention. When we look at neratinib and its toxicity profile, the thing running away are the EGFR targeting toxicities. So for example, diarrhea of 25% at the grade 3 level, higher than what we saw over here. However, unlike earlier studies, we knew this was going to happen. Patients were prophylactically managed with antidiarrheal therapies, and as a result, the overall discontinuation rate between the two arms was essentially equal. It was the same. It was actually numerically slightly higher, but essentially equal between the two arms. So we have gotten better with managing the toxicities with this drug. And we'll say that a lot of our lessons learned were in the adjuvant setting. So in the adjuvant setting, where we use this as a single agent, in that study, we saw in the Extenet trial a number of almost 50% here for diarrhea, and the leading cause for discontinuation. And so the company decided, well, we need to figure out how to manage this better. And they funded this trial called the Control Trial that's been since published. And basically, they looked at all the different strategies for controlling diarrhea. They looked at loperamide, they looked at oral steroids, they looked at cholesterol, a binding agent that causes constipation, and they looked at other strategies. And at the end of the day, they all work to some degree in terms of preventing diarrhea as a reason to discontinue therapy. However, they also found this strategy called dose escalation. So dose escalation is pictured here. For the first week, you do 3 40-milligram tablets, followed by a week at 4 40-milligram tablets, then followed by the full dose. And when they did this, in that first month, only 3% of patients discontinued because of diarrhea. And after that, it was 0 across the board. So this strategy now has actually been adopted by the FDA and has been now included on the label for neratinib in the adjuvant setting. I'll just tell you, I would do this in the metastatic setting as well. I realize it's in combination with capecitabine, but my colleagues and I have found value for this. And if you're going to use neratinib, this is one way to really make sure that the grade 3, 4 toxicity of diarrhea is managed optimally. So lastly, just a focus on HER2 and brain metastases. So this is an incredibly common event for which there seems to be a lack of awareness. About 50% of all patients will develop brain metastasis in HER2 positive setting over the course of their disease. A third of them sometimes with no symptoms. And when we look at when this happens, it happens pretty quickly. The median time for first CNS Met is less than 11 months. And when we look at the proportion, almost 50% or more of the patients are experiencing that Met within the first 2 lines of therapy. So this is distinct from what we observe in other types of breast cancers. When you look at ER-positive, HER2-negative breast cancer, for example, over time, patients receive more and more lines of therapy, and ultimately the cancer seems to set up shop in more and more and more organs, and the brain just happens to be one of them. So it's just a function of how long you've had the disease. Whereas with HER2-positive disease, there is a specific tropism, a desire for this cancer to find its way into the brain. And this is true regardless of if it's HER2-positive breast cancer, HER2-positive lung cancer, HER2-positive bladder cancer. It doesn't matter. If you have HER2, it allows the cancers to go to the brain. What's more, we see this even when we do an exceptional job of managing early stage cancer. This becomes a problem for many of our patients, regardless of how well we do in that early stage setting. So just to recall, the Catherine trial was a trial that looked at patients who had had preoperative systemic therapy with trastuzumab, in many cases, in some cases, pertuzumab. For those patients who had residual disease, historically, we just continued trastuzumab-based therapy. But in this trial, they randomized half the patients to get TDM1, this other antibody drug conjugate. And what they showed is that you could rescue 11% of patients from having a DFS event at 3 years, a pretty big dramatic change. But when they looked at the patients who recurred, it turned out 50% of the recurrences that happened were in the central nervous system. And as an absolute number, that was 5% of the patients in each arm. So basically, these big bulky molecules were not capable, at least in these early stage cancer patients, of crossing the blood-brain barrier and controlling the disease in the CNS. The NCCN guidelines, of course, speaks to the breast cancer physicians, but it also has CNS guidelines. And across all different tumor types, there's some general principles that they sort of provide us with. So if you have, for example, brain-only disease, you can certainly target that brain-only disease with whole brain radiation, with chemoprotection of the brain, SRS in some patients, et cetera. And when there are good systemic options to sort of fold those in, that's the guidance there. Once that's been treated, depending on the patterns of recurrence, whether it's only in the brain or systemically in the brain, and depending on what was previously used. So for example, if you used whole brain before, could you use SRS on a single lesion? Or if you used SRS before, is whole brain appropriate now? These are sort of all spoken to at some level, and then how to fold in systemic therapies also discussed. ASCO and the Society of Neuro-Oncology and ASTRO have also commented on this with very similar sort of guidance in terms of how we mix and match the radiation therapy with systemic therapy. But they also specifically point out the availability of tucatinib for patients with HER2-positive breast cancer. And then the other thing, I know we can all kind of get a sort of woe is us mentality when patients develop brain metastases, but the different kinds of cancers behave differently once they get into the brain. This is some older work from one of my fellows where we looked at patients who had received stereotactic radiosurgery and outcomes based on what type of disease they had, based on the classical breakup of TNBC, ER-positive, HER2-negative, ER-positive, HER2-positive, and ER-negative, HER2-positive. And essentially what we saw is regardless of the type of SRS, et cetera, and systemic therapies available, the patients with HER2-positive disease did better than the other patients. And moreover, if anything, we've got more systemic agents. A lot of these patients actually succumbed to systemic visceral disease and not brain metastasis. So if we can, the message here is if we do a good job in the brain, it really still allows us to continue to target what's going on outside of the brain, and these patients can continue to live and enjoy high quality of life. So with that in mind, let's look at HER2-CLIMB, the study looking at tucatinib added to trastuzumab and capecitabine. This was updated by Nancy Lin, Dana-Farber Cancer Center at ASCO, and then later published in JAMA Oncology. And you can see here at these 12-month, 24 time months, these differences are pretty wide in this group of patients that had CNS metastasis. And if you were to put this table, this graphic next to the OS for the entire study population, you'd be hard-pressed to see a big difference. In other words, these patients are doing just as well as the overall population. When we looked at intracranial PFS, you can see a pretty big difference. Now, CAPE is an active agent in the central nervous system, but the combination of tucatinib and capecitabine is clearly superior. And then this idea that we explored with neratinib in a small way was looked at a little bit more robustly here at this concept of patients who did not have brain metastasis or who had treated brain metastasis. What's the probability of them developing an additional brain metastasis on this trial? And you can see that number is much improved with the combination, including tucatinib as opposed to placebo, a nice rightward shift for this particular survival probability curve. NALA has also been updated. This is the neratinib trial in the metastatic setting. Much smaller group of patients here, about 35, 38 patients in each arm. The hazard ratio is showing an improvement that really mirrored what was observed in the entire study population, a 34% improvement, because it's such a small sub-study, not capable of showing statistical significance. And here again, no benefit, at least for OS in this small subgroup of patients. What about these ADCs? Can they get across the blood-brain barrier? Can they do something over there? Well, it's a little bit of a challenging question to ask based on the data we have on hand. So for example, with DB01 or DB03, the randomized controlled trial against TDM1, patients who had brain metastases were specifically excluded, especially if they were symptomatic or untreated. And so as a result, we have very thin data on whether or not this is useful in active disease. But let's just look at that just for a second anyway. So in this DB01 trial, 24 patients with brain metastasis, some responses for those patients were noted. And when you look at this PFS, it really does mirror what was seen in the entire study cohort. And when they looked at the lesions themselves, there's some hint or some signal that they are responding to this antibody drug conjugate. The caveat here is, though, that right before enrollment, many of these patients had radiation therapy. So what you're seeing here might be ongoing responses from the prior line of therapy, but it is reassuring to say that these patients can still do well and have outcomes that look like what's going on with the entire population. So reassuring, but not firm data. With DB03, a higher fraction of patients with brain metastasis, 24%, some with at baseline. And so that was examined as well. And you see here a hazard ratio of 0.25, 75% improvement. And these curves, even though it's a little more boxy here because fewer patients, it really does look a lot like the curves here on the right for patients who have no brain metastases. So again, reassuring that this drug is not any worse than what would be expected with patients without brain metastasis, even if you had a brain metastasis. I will say, and I haven't shown it here, but there are trials now looking specifically at the activity of these ADCs in patients with active brain disease. Some of that data early on looks really good and looks promising, but I think it's still we have to wait to see what those studies look like when they finally report out their final data. So when we put this all together, this is from another famous Canadian, Shanu Modi, who has presented a lot of this data on the podium and once put this really excellent graphic, in my view, to sort of help us think about how to put this together. And I do acknowledge, again, this is what we would do in the United States. And I realize that some of the algorithms in Canada are a little less flexible in terms of how this can happen. We still rely on the Cleopatra regimen in the first line. For patients who have otherwise unremarkable progression of HER2 positive disease, trastuzumab deruxtecan is now in that spot. And if they got trastuzumab deruxtecan there, tucatinib is a viable option in the third line based on the robustness of the data. But alternatively, TDM1 could also be considered if there's a desire to try an ADC after an ADC. In patients, in the 50% of patients who could have brain metastasis, tucatinib makes a compelling option. And if you didn't get it there, you would get TDXD after that if there was progression, and TDM1 is still available. And then we have all these other agents depending on the context of what's going on with the patient, et cetera. And again, I do acknowledge that this workflow may not work in a place like Ontario. So what about lines of therapy? Can we start looking at that first line of therapy and thinking about it differently? So this is Destiny Breast 09. This is a trial that has not reported out yet, but we expect in the next coming years or so to see this data. One arm is a standard arm, THP, the Cleopatra regimen. But arm A here is TDXD by itself combined with placebo, and arm B is TDXD combined with pertuzumab. So it will be interesting to see what happens here. My sort of concern here is that THP is actually pretty well tolerated. Many patients will drop the docetaxel, remain on HP, and can have a pretty high quality of life on that as long as they're responding. Certainly, if TDXD can push this out longer, it becomes a compelling choice, but you're also trading off enduring side effects that TDXD is capable of causing, as we saw from those data tables. Another interesting alternative is HER2CLIMB-05. I really like this trial. So it takes the Cleopatra regimen, which includes the taxane, and after 4 to 8 cycles, if a patient is responding and or has stable disease, they can then be randomized to receiving tucatinib versus placebo on the backbone of these now subcutaneously delivered monoclonal antibodies. So an oral agent with a subcutaneous drug every 21 days, not coming into clinic all the time, feeling, generally well, as tucatinib is a well-tolerated agent, with the promise of not only improving PFS at all points in OS, but specifically now also being able to prevent the appearance of brain metastasis. So again, don't have this data, really interesting ways to think about this to really sort of change what we're doing in that very first line of therapy. And then the second line, here I'm going to just speculate. HER2CLIMB-02 is a trial that in that second line is looking at TDM1 plus placebo versus now TDM1 plus tucatinib. 1-to-1 randomized trial. PFS is the main endpoint. Just a few weeks ago, Seagen, the manufacturer of tucatinib, set out a press release saying that this was a positive trial for the primary endpoint of PFS. Now, none of us have seen this number yet. We anticipate it'll be presented in the next few weeks at San Antonio. But in that press release, they also go on to comment that there was no OS benefit at this time point. That's not a big surprise. It's still very early. And in addition, they commented that more patients had to discontinue therapy on the TDM1 tucatinib arm than the TDM1 arm. Again, not a big surprise because we're now looking at 2 active agents as opposed to 1. But we just need to look at that data to kind of say, is this a reasonable thing to think about for doing in the second? So just bringing it all together, the summary for HER2-driven disease in 2023, I think We got a little sidetracked with how we look for HER2 because of the DB04 data, but having a rigor and making sure we test for HER2 to identify patients that are likely to benefit from all the therapies we just saw remains important. Sequencing is always an art. What did you do before? What do you anticipate doing next? How effective is it? And what are the toxicities a patient has to pay for that efficacy? All of these are things we're looking at and trying to carefully pull these things together. And then the wild card is, of course, whether or not brain metastases are present. With brain mets, this can kind of disrupt the workflow, at least on our side of the border. And then, as I showed you in that initial graphic, there's just so many more strategies here that are available, combinations that are available, that are being formally tested, and then even more new agents on the way. So this is a dynamic area with a lot of innovation that's ongoing. So when I started breast cancer and HER2 positive disease out in Seattle at the Fred Hutch, I was called a HER2 guy. This is kind of our initial approach. You just threw something at it and try to blow it up and hope for the best. A lot of collateral damage. But now this is kind of what we do, a very precise, precision, judo-like attack on this cancer, and trying to control it, minimize it with as little toxicity as possible. So thank you very much, everyone. That's the last one. Stop sharing.
Great.